1 in 5 Medicare patients gets readmitted to the hospital unplanned. And every time they get rehospitalized, they come out often a little worse than they were.
When you are at the hospital, you get a lot of care. Being home, you're alone.
The reason why Mills-Peninsula looks at readmission rate is that it affects the quality of care that our patients ultimately receive.
We had variable, inconsistent transitions. We just didn't have a streamlined approach of how patients left the acute care facility. We did our best, but we knew we could do better.
In 2011, when we first started our transitions work, we received a planning grant from the Gordon and Betty Moore Foundation. We were able to do an internal gap analysis. We looked at common reasons why patients come back.
We actually did pretty in-depth root cause analysis, both from the hospital perspective and from the community perspective. What we learned, to our surprise, is that many times it's really not the medical components that bring them back. They may have worsening symptoms, but it's really the social aspect.
They live alone. It's hard for them to get out of their house, so to get food, to get groceries, to get to their appointments. Also, low health literacy, so a lack of understanding about their disease or medication.
We created an internal risk tool to prevent readmissions and improve the discharge process. Once the tool was launched, we knew we could focus more on the high-risk patients.
One of the very important key interventions has been the teach-back method. With the teach-back method of patient education, you listen first to the patient, you get their story, and then you start the process of educating the most important key points and then reassess to see where the gaps are. It will allow them to answer questions and have discussions with their families that they may have never had before.
One thing in particular is the pharmacist intervention. It allowed us to bring in pharmacy technicians who will do medication reconciliation.
I connect all the pieces, what happened at home before hospitalization, during their hospitalization, and what's going to happen for them when they go home. Where most pharmacy involvement is really focused on what's happening while they're here in the hospital. You really felt that when the patient goes home, how are they going to figure this out?
The Moore Grant enabled us to assist seniors as they leave the hospital and really looking at addressing some of their medical and social needs.
The Transitions of Care provides a bridge for not only the patient as they transition back to their normal life, but it also provides the healthcare team within the hospital to have more of a connection to the patient and to actually find out how they're doing and help them achieve their goals of getting better or whatever it might be that they would like to accomplish.
What we learned from the Moore Grant was high touch, close contact with patients is really important. So how do we systematize that? One, of course, is the follow-up phone call program. Patients need that kind of engagement and that kind of touch back to the people who had cared for them or know about them and their condition.
The other really important piece is the follow-up appointment. If they don't have the appointment made, I ask if they want me to do it. If they don't, then I'll follow up in another 2 days to make sure they did.
I think the home visit is very important for helping to smooth the transition from hospital to home. It enables us to review the discharge instructions, but also to establish what the patient's goals are.
While the nurse really focuses on the clinical issues, the social worker focuses on the psychosocial issues, gives emotional support, helps link the patients and their caregivers to resources in the community.
Some of the things that we discovered were gaps with the partnership with the nursing homes, that we needed to work closely with them.
Skilled nursing facility patients are very fragile and a very high risk of being readmitted back to the hospital. Telepresence has changed the communication between us and the skilled nursing facilities. It really has established a relationship. The effect in the patient individually is that the plan of care that was started here at the hospital was continued at the skilled nursing facility.
In the past 2 years, we've been able to reduce 30-day high-risk readmission rates by 30%.
About 18 months into it, we started really seeing the numbers go down, and now we have huge readmission reduction programs. It's gone far beyond heart failure. We've got a lot of players at the table that were never there before in the outpatient setting and here within the hospital. And not only that, the IHI has recognized our program as being very successful. If I was telling another hospital that was just getting started how to do this, I would say first and foremost that it's all about developing relationships. You want to meet the people that your patients are meeting and really talk to them in depth about what your goal is, what's worked, what hasn't worked, and to make sure that it's a two-way thing. Many of the answers are outside of these walls.
The incredible positive feedback from our patients and their families has been tremendous. Our partnership with the community has been very fulfilling, and our board has been extremely supportive. I would really encourage other hospitals to look at similar type transition of care programs. It provides a higher level of patient satisfaction and ultimately decreases the readmissions, which is also an indicator of quality of care.